Hello and welcome to COVID Weekly. My name is Dr. Craig Martin. I'm an infectious disease pharmacist and professor at the University of Kentucky College of Pharmacy. I'm joined by my co-host, Dr. Dave Feola, who's an associate professor and my personal go-to expert for everything related to the immune system.
Craig, thanks so much. As you are as well, I know I'm really excited to embark on this podcast with our very first episode. And I can't think of a better guest expert to have on our first episode than Dr. Rebecca Dutch. Dr. Dutch is the professor and interim chair of molecular and cellular chemistry here at the University of Kentucky College of Medicine. She is a virologist and studies many pathological characteristics of viruses, and she came to the University of Kentucky after receiving degrees from a couple of small schools that people may recognize, including Michigan State, Stanford University, and Cambridge University. So, Becky, I was relating to the production team that you and I have been on a few committees together over the summer and fall, and it seemed like we would have at the start of each meeting an obligatory let's pick Dr. Dutch's brain about all of the therapeutic and scientific information that was coming out about coronavirus really at an unprecedented rate. Can you tell us what the last 8 or 10 months have been like for you?
I will say I've worked more hours a day than I've ever worked in my life. So my expertise, my research expertise has always been on molecular under respiratory virus infection, the RNA viruses and emerging viruses. So while I wasn't a coronavirologist, I had a lot of experience in the area of understanding viral infections and understanding emerging pathogens. And that put me in a position where suddenly there were a lot of ways I felt like I could help with this pandemic, both at the university level. So in addition to my own research, we launched into some work on SARS-CoV-2 in the lab, helping the university with what's called the START team, which looks at decision from the medical standpoint, decisions on campus practices, with the Cure Alliance, which is an alliance that the university put a lot of funds in to help get clinical trials, research, and knowledge about COVID-2 in. And a huge portion of it, particularly in the beginning, was trying to keep up on the vast amount of literature that was quickly coming out, most of it on preprint servers. And because it was on preprint servers, it hasn't been reviewed, and you have to look through it at least some to see how valid you think the comments are, knowing that in some cases, these preprints were being used to try to help determine patient care. So it's been quite a year, a lot different than the normal research science that I do, which doesn't have a frantic pace to it, quite the same as this year has had.
One of the things that strikes me is that coronaviruses are not new. Maybe they didn't enter the consciousness as much as they have in the past year or so, but why is this so different? Why is this different from the other circulating endemic ones that we've had before?
Well, coronaviruses aren't new. There's lots of different ones. And prior to this, we really had 6 in the human population. So the 4 of those are what we think of as endemic cold viruses. They're viruses that have been around for quite a while. And for the vast majority of people, they cause colds. For some people, particularly older people, you can be quite sick with those colds, but they are rarely fatal. They rarely put you in the hospital. We've had 2 previous outbreaks that were very concerning with coronaviruses. SARS in 2002, the original SARS. When that one came out, fortunately, it didn't spread as well as this one does. And so we ended up with a little over 8,000 cases in the world, but the mortality rate was about 8%. So that's very scary. And that one just went away. We haven't had another case since 2003. The other is MERS. So MERS first emerged in 2012, and actually we continue to have sporadic cases. It spreads very poorly person to person, but has a very high mortality rate in the 40+% rate. Those are related to SARS-CoV-2. So virologists had coronaviruses. There's a small set of viral families that you got your eye on for things that could cause pandemics, and coronaviruses were definitely up there. In fact, some colleagues and friends of mine had done some studies with bat coronaviruses, and they really predicted what are the various things that might show up. And SARS-CoV-2 has elements of some of the things that they predicted, not exactly the same. Nature surprises us. This one is very different because of several things. Number one, its transmission efficiency. It transmits very effectively. It's what called R0 value. That's how efficient it is person to person. It's probably somewhere between 2 and 4, depending on your studies that you have, which means for each person that gets it on average, they spread to between 2 and 4 people. So that's one thing. The other is this issue of having people spreading it very efficiently before they either get symptoms, and some people staying asymptomatic, never really knowing they have this disease, but still spreading it. And those two things make it very hard to slow it down. So those combinations have turned this particular virus infection into a worldwide pandemic we're still trying to control.
Absolutely. And speaking of the R0 value and other characteristics, I think something on everybody's mind right now is the emergence of these new variants that we're hearing about from, I think, Brazil and now Southern Africa and the UK. What's the significance of these new variants? Are the R0s different, and are there any other aspects of the new variants that really pose a threat therapeutically that we know of right now, or maybe how the vaccine is or isn't as effective?
So first, it's probably important to point out that the slow generation of changes in these viruses is expected. This is not that surprising. When viruses replicate, when they replicate means make copies of themselves, they make mistakes, and they make more mistakes than we do. Now, coronaviruses correct some of their mistakes more than some our viruses do, but nowhere near as well as we do in ourselves. So what it means is they continually generate variations, and some of these variations have changes that get picked up, and if the change means that the virus is improved in some way in terms of transmission, you might keep it. So that's why we see variants. And right now, these variants have small enough changes. We don't call them strain changes. They're variants. So the 3 that you brought up are all being tracked pretty closely. The one in the UK was first appeared around in November. It's difficult to answer exactly the question of the R0 value, because that requires, even for the original Wuhan virus, you'll notice I gave you a range for R0. And that's because depending on how you study it, where you study it, those numbers look different. Because how efficiently one person spreads to others is going to depend not just on the virus, but their conditions. If they never see another person, they're not going to spread. If they live with 150 other people, their chances would be greater. So all those things influence R0 value. There's some evidence from the British strain or the one that was first identified in the UK, that it may transmit better. That's based on watching epidemiological patterns. And they think it's possible the reason it transmits better is because some of the mutations picked up are in what's called the receptor binding domain. It's the part where called the spike protein, the thing that sticks out on the virus, it binds to something on the surface of a host cell to stick there so that it can enter that cell. And a couple of those changes appear to make that sticking process more efficient, which would likely make it easier for you to get a virus into a cell, which might improve transmission. There's not yet been any published data to say that that variant in the UK or the others are more what's called pathogenic, which would mean making you much more sick or more likely to die. There was a news report about that a week ago. I have yet to see any data that actually backs that up, and I've seen some data that suggests it's not true. So we have to keep an eye on that. But it does appear that one is more transmissible. And actually, variants that are picked up that are more transmissible make sense from a virus evolution standpoint. As viruses slowly change to adapt to the population that they are now resident in, so SARS-CoV-2 in humans, mutations that make transmission better are the ones that get propagated better. So those are the ones that are often seen. And so we're not surprised with these, but we do need to be cautious. So one thing, all these in terms of what to do about them in the short term, really being very careful about your protective equipment, your distance, your weather. It just makes it easier to pick this up. That's the first thing to remember. In terms of whether they create problems, There's been one report that one of the South African variants may affect one of the monoclonal antibody therapies that's coming out. So far, the study suggests that the vaccines, particularly Moderna and Pfizer, have both been looking at this carefully. Their initial data suggests that the vaccines still protect nicely against these variants. They will, however, be continuing to track all major variants that are showing up, with the idea that if it turns out there's a newer variant that creates issues, that you would then need to adjust or give a booster.
I see.
That would help you with that.
It's really fascinating how the virus really responds and the evolution of it throughout the world. And something you said that was really interesting there. You read a news broadcast about some potential emerging data, but hadn't seen the data itself. I saw a quote from a policymaker at the CDC who said, it's really tough to write therapeutic guidelines based on news stories and press releases, because I know a lot of these, companies have come out with press releases about how a potential therapy might be affecting, but until we see that data from the studies, it's really difficult to make those interpretations.
That's been a challenge this last year when science is moving at the speed that it's moving, because of how important this is. We get all sorts of either news broadcasts or even preprints that generate interest, that generate almost clinical decisions before we really have firm data to say whether it's good or not. The most dramatic example of that was back in March with the hydroxychloroquine preprints and things that came out. Normally, you'd have clinical trials that would tell you whether something was effective. And I will tell you, as a virologist, anybody who had studied viruses for a while, we were all predicting it wasn't going to work, because hydroxychloroquine works on it sells all sorts of viruses in cell culture, and it never works in humans. But the whole press issue of they picked up, one random paper or one preprint, and suddenly it's everywhere, can make science really difficult, because you need to carefully watch the data. You need to carefully examine the data to know if something's really effective. And without that data, you could be making recommendations that are actually harmful.
I'm certain, just as you and Dave have gotten comments and questions from family members and colleagues and things like that, I'll occasionally get a text from a family member that says, "What do you think about X?" And lately it's been, "Oh my goodness, there are new variants already." And my answer back to them is, yes, this is what viruses do, and it's sort of like evolution in warp speed, and we can expect some things to change. And it's been challenging for me personally, but also I think back to last April, and there was a run on hydroxychloroquine and azithromycin, to the point that the Board of Pharmacy in Kentucky restricted the dispensing of those because they had to be preserved for patients that needed it for other legitimate indications. And so you're right, having that news report prior to the actual data is a challenge on multiple levels. I'm interested, we've talked a little bit about mortality rates and things like that. And I remember when this was still developing in the spring of 2020, it was really hard to get a handle on mortality rate, because testing wasn't at the level that we really wanted it to be, and we were only seeing the sickest of patients, and that skews mortality. Do we have a better sense of what the mortality is nowadays?
We have a better sense. It's still difficult to have a completely firm number, because it's very dependent on the population. So there was a really nice paper, I believe, in Science about 2 months ago that took studies from all around the world of not just mortality, people who were dying from COVID, but also looking at antibody prevalence screens, things like that, to get a good sense of what the total population that had been infected was. The other important thing that they did is try to break it down by age, because there is a tremendous difference in mortality rate from this virus depending on your age, and then also on some of pre-existing conditions. And so that paper suggested that up to around age 70, it was pretty consistent around the world. Very low mortality rates in the young. Their number for ages 5 to 9 was like 0.001%. That's extremely low. And that would actually fit with what we've all heard so far. You have an occasional case of a child who gets very ill, but it is extremely rare. And then it just slowly increases as you get older. So you're still extremely low in your teens and your 20s, but slightly higher than you were when you were 5 to 9. By the time you're getting to in your 50s, it's more like 0.8%. And by the time you get above 80, it looks like it's around 8%. Now, that 80 above that, in the very oldest groups, it varies more around the world, likely because depending on where you are, you may have more people who are still alive with very serious pre-existing conditions, and other places you have less people who have survived, depending on what healthcare was available. The other thing is it depends probably on living situation. If someone who's much older is living with large groups, they are much more likely to be exposed, but they might get better care. All those things change. So there was more variability in that number, but the average was around 8.2%. So in those highest groups, that's a very high mortality rate.
I don't think a lot of people understand how high 8% is in that older population. As you mentioned, that's a big mortality rate and something we should all be paying attention to.
That is, I mean, the way to always think about it. So I teach virology here, and one of the things we'll always point out when we talk about mortality is smallpox, 30%. Some of us think, oh, that's not so bad. 70% of people survived. Then I said, okay, look around the room. We have X number of people. That means this number of people will die. And suddenly, if you think 8%, if you were in a large room, you were doing an event and you had 200 people, that would mean if everybody got it, 16 of them would die.
Right.
I think it's extremely impactful. I think, another really interesting and of course tragic part of the pandemic is how it seems as though, although we know that the pre-existing conditions increase the likelihood of mortality and also age, it does seem that there is a random severity, whereas some younger, healthier folks do respond very poorly and can either end up in the ICU and then recover or not. What has there been any data emerging surrounding that? I know there are some genomic studies going on to try to pinpoint exactly what other risk factors there could be. Are you aware of any recent studies on that topic?
So we know some things clearly. If you have issues like high blood pressure, particularly uncontrolled high blood pressure, things like that, it is a major issue. Actually, one that comes up over and over again is a high BMI. The thinking is that when you're carrying a lot of excess weight, your body is already in a somewhat inflamed state, in the sense that your immune system, it has an inflammatory response. It's almost constant, and these respiratory viruses ramp that up even farther, and that's part of why people get so ill from these viruses. There are some studies going on, and they have some linkages. There are a few specific issues related to people's genetics, how they have influenced certain immune cells that can have a major impact. So they've identified a few of those. There have been studies that suggest potentially there's a link to, for instance, blood type, but the confusion there is that actually that locus includes also other genes for the immune system. Not clear that it's a blood type issue. It may also be, the minor variations that exist between each of our immune system responses. So those are some of the ones that they're honing in on. There's likely a lot more, but I think those are some of the major ones. Minor changes between the way certain of our immune cellular responses work, and then changes to other things like those kinds of pre-existing conditions, such as high BMI, high blood pressure, diabetes, that might be related partly to those other issues there. So there's reasons behind some of this, but then occasionally we'll have something. I know they have patients that they cannot yet understand why their response was so much worse.
So I want to talk about a term that those of us in infectious diseases have heard for a long time, but just recently entered the lexicon of sort of society, and that is herd immunity. I don't think the average citizen had heard the term herd immunity until a year ago. And I think, unfortunately, it has become sort of politicized a little bit, but it's not a political term, right? It's related to how many of us would have to have immunity to a certain virus or infectious disease to prevent that from being spread in the community. I understand that we don't exactly have the R naught of this virus nailed down, and so it's really hard to know what level of immunity needs to be prevalent in the community to reach that herd immunity state. What's your best guess on how many of us would have to have some immunity before that stops?
I think the number is going to be somewhere between 80 and 90%. Again, it's difficult to nail it down completely because it depends on transmission rate. So as an example of a different virus where the discussion of herd immunity has been out there, but not been as publicized as it should be, measles virus. One of the reasons that we are so concerned about people declining measles vaccinations is that measles has an R naught of about 15. It's tremendously high. It spreads extremely well. And you need a very high, over 95% vaccine rate in order to protect the people who can't be vaccinated. There are always people who can't be vaccinated. They have immune system issues or other things that mean that they can't take the vaccine. So that the better it spreads, the higher you need that herd immunity to be. For something between a 2 and a 4, 80. If it's 4, we may need to get up to the 90 range. If it's 2, 75 to 80 is probably okay. Though that's the reason you hear some variability when people give these numbers. It's not that scientists are intentionally not saying the truth. It's that it's in that range, and we'll have to wait and see. But it's pretty high given how well this spreads.
And I think that really brings into focus why we need vaccinations, because if we simply wanted to get to herd immunity through natural infection, that's an incredible amount of infection. And given the mortality rates we've just talked about, it's also an incredible amount of death, not to mention the long-term health consequences that we don't really have fully elucidated yet. So I think that's the part that I think folks have to really keep in mind.
Absolutely.
Yeah. I think that unfortunately, there's been some effort for people to underplay how serious this could be. And I understand when you're in your teens or your 20s, the risk to you for dying from this is very low. Now, there are other risks. Some people do still get quite ill at that age. Some people do have long-term side effects, particularly heart and lung issues we're seeing come up. But the other thing is, how do we as a society take care of each other? And that's one where I wish we could have more conversation about that. That we have always historically been a society, or we have been for many years, where caring for those around us was a part of our job. And that's a part of what our response needs to be to this. This isn't just for me. My kids were not vaccinated for all these other things just for them. They were also vaccinated for others.
That is very well said.
Very well said, absolutely. And, the vaccines that are available now give us a lot of hope that we can begin to see the prevalence decline as we get more and more folks vaccinated. And at this point, we wanted to ask you, what are the most interesting aspects today, either about the vaccine or about the virus, that are emerging from science that we haven't touched on yet today? Are there any other aspects that you'd like to share with us here before we wrap up?
It'll be really interesting to watch and see what happens with our long-term immune response to these viruses. Obviously, that's been discussed all for a year. Back in March, when people said we might not become immune, most of us who are in the field said, well, no, I doubt that. I think we'll have some immunity. For how long? And that's I think we're going to learn a large amount, because we have so many studies going on about how the human immune response is to these respiratory pathogens and what parts of the immune response are most important. So I think we're going to learn a lot that's really interesting about there. I think that we should hopefully take this and start to really look much more carefully at questions of the virus evolution and virus emergence. This is every year when I teach my virology class, we do the last things on emergence. And we always talk about the fact there's going to be another one. There will be another pandemic. Every year when we teach that class, we have a new one to talk about. It could be the outbreaks of Ebola. It could be the Zika outbreak. MERS. I mean, so it depends. But we need to get much better at understanding what could come and understanding how to address it. So one of the things I'm hoping we will see, and they're starting to work on it, is an increase in research, understanding how to develop almost a baseline or a foundation of antivirals that you could start with for the next thing that comes out. We know a lot of these targets. We know what we could go after. For instance, we had remdesivir. We knew in March what the disadvantages of remdesivir were. We knew you couldn't give it orally, so it was likely to only be given late. That was likely to be a problem. We knew about its liver issues. But we had that because it had been tested. If we had 50 RNA-dependent RNA polymerase inhibitors that had all gone through phase 1 trials, we might have been in a much better position to have an antiviral that was effective early on. So we're starting to do we're doing some of that research. But I think some of our research for this needs not just say, how does SARS-CoV-2 work, but how do now we understand what might come next and how we might target it. SARS-CoV-2 is a beautiful way to keep the pressure on, to really dissect each step of its infection pathway and understand what we could develop to target it next time.
Absolutely. And I'm hopeful that that's one thing that comes from this, because we absolutely need more drug development and more research on viruses and emerging viruses and how they can come. I remember you making a comment about some of your friends that study coronavirus, how they were having difficulty getting funding and keeping their lab programs, the research programs going, and now it's completely changed and it's their heyday.
As of March of 2020, the coronavirus community is quite small. Wonderful people, very dedicated to it. But yes, when SARS emerged in 2002, suddenly there was a pot of money, and then it kind of went away. MERS gave a little tiny boost, and then it went away. Actually, the gain of function ban stopped research on SARS and MERS, essentially. And we were very short-sighted. We didn't keep pushing on this. You're completely right. I had a friend, an excellent coronavirologist, who literally put a GoFundMe site up, trying to get enough money to keep pushing on some of these inhibitors he was working on. Yeah, when you think in retrospect, that's incredibly sad.
I think that, coming from the bacterial world as I do, there's so many echoes of mistakes that we've made with antibacterials and bacteriology, and we wait until there's a crisis before we put money toward that problem, and some of those things, as you mentioned, we can see coming, and so we need to really change.
Yeah, we will have another virus emerge. I hope in the next 20, 30 years we don't have anything as serious as SARS-CoV-2. But if you look at the last 20 years, SARS, MERS, Zika, multiple Ebola outbreaks, H1N1 in 2009, they're coming. We keep seeing new viruses. We aren't taking them, I think, nearly as seriously as we should have been taking them.
I have sometimes have had conversations with family members that hear things like, well, this is the worst pandemic since 1918, and they believe that this is the only one that'll happen during their lifetime. And my message to them is that is unlikely to be the case. So I want to ask you one question as we sort of close out here, and it's going to require you to look into the future a little bit. And we have a virtual office pool going, but I'd like to get your prediction on what our lives will look like in 6 months. Do you expect people to still be wearing masks inside? Do you expect us to, let's say, at the University of Kentucky, be gathering in full force for fall football games? Do you expect high school football to be going on? Anywhere you want to take that, what does it look like toward the end of the summer?
I can give you my guess, but I want to really, really tell you and remind you this is a guess.
We will not hold you to this, I promise.
I always worry because sometimes people really will hit, oh, that person lied to us and so and so. And I want to make sure that there's places where the science gives us strong information. There's places the science guides our guesses. And this is where it guides our guesses. If we can get high level vaccination with the Moderna and Pfizer vaccines, which I think by midsummer, we could be getting to a point where we're getting herd immunity if we can get people to take them. And I don't mean, a lot of people are, but I mean, we can really get that 85%, 90% buy-in to this. Then by 6 months from now, I think those masks are coming off. We don't know for sure right now how much these vaccines drop transmission. I will tell you, I would be absolutely shocked if they don't drop transmission at least a considerable amount, because they clearly drop virus replication because people aren't moving to that symptomatic phase. But we do know that they're incredibly effective at blocking serious infection. And once we're protected against serious infection, we can go back to a much more normal life. On the other hand, if we have more trouble with the rollout, or we get a good portion of society who says, well, I'm not taking it, then it gets more complicated. And then we really have to be tracking what percent of people had it, what percent of people had the virus, what percent of people have antibodies, and looking very serious at those questions. Long-term, humans don't do well with social isolation. We need to get things back opened up. As part of the START committee here, one of the reasons we pushed for the reopening in the fall was the understanding that the virus is not the only risk here. And for our college-age students, the mental health risks from social isolation are huge also. And it's not just for that age. This is really difficult on lots of people. So I think if we did what we can, if we did it right, I think in 6 months we could be going back to pretty normal. But with a lot more, I think for a while, we're going to need to have periodic testing and really good surveillance to make sure that we're not having new outbreaks popping up. And they're going to have to really watch and see how long the immunity lasts with these vaccines and whether we're going to need boosters. If I look 10 years out, I think there's a good chance this virus will be endemic in the human population and mostly just a cold virus like the other cold viruses we get. Look at what kids don't get that sick from it. So if that's the first infection, you get some subsequent ones and you have some protection from the early ones, you're likely to be not getting all that ill from it. So we may well have, this may be not the big issue that it is now if we look 10 years down the road. But in the interim, we're just going to have to keep a close eye on.
Well, I, for one, really hope your 6 month thought is true, because my family's got a vacation they really want to take this summer. They had to skip one earlier during this pandemic, so we're all looking forward to that for sure.
Yeah, I hope so. I think so, but I've been surprised this year, and I've been surprised by some of the ways where I thought we could get things rolled out, or we thought we could do things. I thought we get more buy-in, we haven't. So that's what it'll depend on.
Sure. I tell you what, I've really learned a lot during this session, and I don't want to speak for Dave, but I'm sure he has too.
Absolutely. And we knew this would be the case. I think this has been a great first episode. I think having your perspective, it has been really valuable to communicate, and hopefully we'll get a great audience with this podcast. Thank you for your time this morning and coming on with us. Thank you for all the work you've been doing for our university and really for our state and really beyond. So we really, really appreciate it.
All right. It's been a real pleasure talking to you guys.
Thanks, Dr. Dutch.
Take care. Thank you so much.
Bye-bye.